Hear this, ran out early, took too much. There are two things, a couple of things. What will happen is, I'm on my Suboxone, but like I said, my girlfriend Rona with my buddy stole my pickup and shot my dog. Remember the kappa activity goes up. I don't feel so good, so I take more Suboxone. My explanation to the person is this, and I don't know that it will hold scientific accuracy, so those of you who are pharmacists and scientists, don't hold me to this. I say, look, what you're doing is a 3-day drug, and you're setting up these waves. You took the dose, you took more, you took less. I said, that's going to ruin the effectiveness of the Suboxone. What I want you to do is take the same dose. On a good day, it's beautiful out, you think you can cut your dose, don't cut it. On a bad day, you feel terrible and you want to take more, don't take more. Keep the Suboxone level and the brain will start to match the Suboxone. It's an illustration, but it works. And they'll go, oh, because what you're taking, you're also, the psychologist amongst you will say, what you really did, John, was you took them from I feel, therefore I take, to I need to learn to follow a level life. And that's where you're heading them. Get oral sores in the mouth. If you go to, they're on the tablet and they go to switch to film, a small number of patients, around 4 to 5%, will get some sores in their mouth. I'll switch them to the tablets or to Belbuca, which is the one that goes inside the cheek here. It works, and usually the problem disappears with that. Okay. They request Subutex. We get this. Someone will come in and they'll say, well, I'm on I just saw one this week. He was discharged from a local facility in Portland, and he was on 24 milligrams of Subutex when he hit my office. You know what I feel about 24 milligrams. But you want to go where the patient is. So I kept him at 24. I say, we don't use Subutex here. Why wouldn't I use Subutex? Number one, he's not pregnant. Here's what's nice about Subutex. You go to France, Subutex, buprenorphine, has now passes heroin as a drug of choice on the street. IV-wise, you can take the buprenorphine, the Subutex tablet, and that ain't the same thing as putting it on in your mouth, folks. You're lucky to get a 20 to 30% absorption transorally. Belbuca maybe get up to around 40%, but nothing will match an IV. And what it will do, it can get you high. It can also, if you got the Joneses and you're kind of coming out, it will let you down gently. I can take it once a day. Many of the street people I run into can take it once a day. And 8 milligrams, and they're pretty well happy. So I've kind of got mixed feelings how much Suboxone should be on the street. I've had, whenever I get a new person that maybe has had some street history that I suspect, I'll say, have you ever tried this before? Yep. Where'd you get it? From my buddy. I said, okay, you got some experience, let's go with it. But I just tell them, you won't get Subutex at this clinic. Well, it costs a lot cheaper. It's not going to happen in this clinic. It will not do it. There are clinics in Portland. I said, if you want Subutex, go to Portland. For you in Portland and legs, I'm sorry about that, but that's the way it is. Don't be Dr. Nice and prescribe it at their request because you want to save them money as they stuff out a cigarette out there in your ashtray. No. It's just a rule. We never use Subutex except for pregnancy. I'll take it back. There's one person we have a true naloxone allergy to. It's a very small number, but that's after hundreds and hundreds of patients over years and years, so it's mighty rare. Edema. Your patient comes back, you've done a home induction, they come back, and maybe a couple weeks later, maybe even by then, they're starting to put on a little weight, and they ask you. If they're just a little weight, have them weigh daily. If they start developing edema, stop it. Don't even bother with diuretics. I used to try that years ago. It doesn't work. It can actually push them into congestive failure and end up over there with our hospitalists at Sound, getting them out of congestive failure that I put them in. It's a rare side effect, but it happens about once or twice a year in our clinic. We'll see it. Okay. Nausea. About 10% of the people will get nausea from the naltrexone. Got that wrong. And that's because they're swallowing it. Administration technique, head dependent. When you're done, spit it out. You're done. We've already hit this. They come in on high dosages, transferred in. hospital usage. It's for the hospitalists. They know this already. They can prescribe, as ED physicians can. They can do it for 3 days. They can cover it. They don't need it. They do not have to have a Suboxone. I think we're good in the future. You're going to see practically all the ED physicians Suboxone certified. You're going to see hospitalists, and they're going to think that's just another drug. It's like treating diabetes. It's not any different. It's simpler than diabetes. Now remember, precipitated withdrawal, if they start their Suboxone early before they've got it all out of the receptors, they're going to have a precipitated withdrawal. And that's why I really emphasize to my patients on a home induction, I want you to put yourself into withdrawal. I do not want the pill to do it because it is vicious if it does it. And I remember when I first started using this drug maybe 10 years ago, I had a couple calls from the ED. You know, what do? We give them a couple liters of fluid, give them Suboxone, they'll be fine. But you don't want to do that. It's not, you want to be nice to people. These people have had enough trauma in their life. They don't need me adding to it. But you can add, once you're on Suboxone, you can add any narcotic to it in the world. So, the patient I saw this morning, this is going to make you cringe. She's 19, she just turned 20. Her prescription is oxycodone 30 milligrams, 1/2 a tablet, 6 times a day. Okay. She has a very difficult case of Crohn's. She's being seen in Seattle. They're getting her ready for her. She's the only person I've seen, I've never seen a person this age that says, please give me my ileostomy for life. I do not want this. I can't keep living this way. And she's one of the few people begging for the surgery. I've met part of her family. She's probably the only sane person in the entire bunch. Well, what we did with her, because she was on a lot higher dose of narcotics, that's what we had her on this morning, and she's been on that, and as soon as she gets her surgery done, we're going to go full blast Suboxone and start tapering her down and try to correct the damage that I am helping to produce in her right now. So what did we do with her? Well, you can add narcotics to Suboxone, but it depends upon the dose of Suboxone. So remember that slide we saw earlier? At 2 milligrams, one study shows we got this many receptors blocked. At 16, we got that whole bunch over there blocked. At 30, on up the line there. You kind of see the stuff there. So what we did with her is she's on 2 milligrams a day of Suboxone. That can give a pretty good blockage at 2 milligrams. Okay. Same thing you just saw. This was made for the hospitalists, this slide. They can use fentanyl, will override Suboxone any day, but it's got to be IV fentanyl. So they come to ED, they're on Suboxone, they just tore their leg off, IV fentanyl, works well. But if they're on, let's say, 12 or 16 milligrams, I tell them, I'll cut it down to 4 milligrams and then throw narcotics on top, keeping in mind you're blocking a lot of the receptors. So what we do normally in the hospital, and as you see, it's up and down. This is when I push the button, call the nurse, I get the pill, I feel better. Whew. Narcotic wears off, hit the button, give me a nurse, I need another pill. And we keep going up and down. So one of the tricks of the trade, we'll put a baseline of Suboxone in. So what we were able with her, we've reduced her dosage of opioids by 1/2 by putting in a 2 milligram basement. So what happens, I feel better, I feel worse, I don't feel that bad yet. Now I'm ready, I can feel that. And so we cut the bottom out. When they hit that bottom is what drives the button. Either call the nurse or get me another pill. So we're cutting that out. So we'll see patients on a low dose of Suboxone and we'll throw full agonists on top. But use it for very, very selective. I've seen this done by some, and I'm going to call them lazy doctors. You complain of pain, oh, just cut your Suboxone down to 8 and give you a bunch of narcotics. And that's just bad, lazy medicine. There's some attorney, big attorney firm in Portland should hear about that. Okay. No narcotics on, we'll do what we did with her, 1 to 2 milligrams, something like that. Add the opioids on top. Okay. If they come in on Suboxone, we have a choice. We can stop the Suboxone, but then you got to make up for what the Suboxone was doing, plus give them the stuff for the leg you just amputated. It's a bunch of narcotics. What's the normal amount of narcotics a patient should use? Here's the problem we have. This all started in I hope I've got this slide up here. We'll find, yes I do, it's the last slide. What's the normal amount required for pain? The problem is we have physicians that have been taught to treat pain, but have never been taught to treat the problem. Before 1996, you broke your leg, you did this, your doctor said you eat a couple of Vicodin for a couple of days, put your leg in the air for the sprained ankle, and that's all you get, and take some Tylenol and aspirin, you went home, and that was it. And everyone had the same expectation. I didn't bring you the slide, but Adam, one of your hospitalists at Sound, is Adam still with you? Yes. He actually shows up in one of my lectures. He doesn't know it, but I got his card and I took his picture off of it. Adam, where did he come from, Stephen? Eastern Europe? Yeah, Poland. He came from Poland. And I'm talking to Adam. He's a bright young man, one of the hospitalists here at Peace. He came from Poland, so I asked him about medicine in Poland. He was in the intensive care unit there where they did thoracotomies and things. And they did the thoracotomies, and I said, well, tell me about what you use for pain management. He said, well, it's pretty standard. We do the things, pull the drain out of them, you know, sew up their zippers and all that, and send them home. What's your standard? So, oh, it was, yeah, they were given tramadol, 50 milligrams, 20 tablets, and Tylenol. And that was to last them and take care of their pain post-op. Well, how about refills? But we never got any calls. They set the expectation. Now, in this country, what do you think you're going to get? So remember, nobody takes their first narcotic is heroin or fentanyl-laced heroin. Their first narcotic came from one of our prescriptions. And if we're going to point fingers, we better go look in the mirror, because we're doing it. And I did it for years, folks. So how much you need for pain? Well, let's do a little research. This was nice. What they did in this study was really kind of cool. These are the procedures, for those of you who can see it. They called them up a week later after going home. They said, how many pills did you actually take? That was the average number that 80% of the patients took. Compare that with the prescriptions you commonly see and we commonly do. That bottom one, the thoracotomy, just blew me away. Then I said, wait a minute, that's what Adam was telling me. I have trouble believing this zipper down the front. It's amazing. And my wife had a reverse total shoulder about 8 weeks ago. Her narcotic use, she was given a prescription for 45 milligram oxycodone. She didn't fill it because she had oxycodone in the safe left over from her previous total knee. She took a total of 3 pills. That was it. And how much did she take with the total knee when she went home? She took 3 pills, total knee replacement. So my wife's not really tough. She's no tougher than I am. I'm a wimp. But that shows what people really take, but that's not how we've been taught. Well, I like the orthopedic stuff because simply, when you complain of your back pain, I did your MRI. I can tell you, it looks just like his MRI and his MRI, and her MRI looks a little different. She's got degenerative disc disease. I can't really tell what you got. But I tell you what, if you get a fractured arm, then I know it. Because we can see the tissue damage. They got pins in them, they're in surgery, and there's no question about it. So the question is, what correlates with opioid use in fracture pain? Fractures, number of fractures, days in surgery, none of these have any correlation. None. What does correlate? Same study. That determined who used the highest user of opioids during the hospitalization for orthopedic fracture care. Bingo. So that's kind of my patients say, what do I get post-op? That's pretty well my top line. It's what they get. So are we treating psychological problems with narcotics? What do you think? This is opioid use. As you can see, about 1996, the red line is the United States. The black line is Europe. And this continues to today looking like this. So what occurred before 1996, you were told to treat the problem. If you sprained your ankle, this is what we did. You did this, this is what the treatment was. Family doctor, everyone knew. We all pretty well knew it. If you got a prescription for Vicodin and more than 6 tablets, it was amazing. 12, the guy's radical. He's going to go to hell. Could be. But in 1996, we decided we could treat the complaint of pain. So all you had to do was say, I have pain. Whoa. And look what we did. The expectations in Europe were the same as Adam had in Poland. The expectation was that will work. The expectation is they still treat the problem. Only in this country do we do this. So I think that's the final question. So is Suboxone for addiction? It can be used for addiction. It can be used for other things. Is it the perfect answer? It's not. But I would really want you to give serious thought. Look at what's happening in your community. Look what's happening to your patients and your neighbors' patients. And make some decisions. Do we owe it to our patients to try to correct what we have created?